Hi, I'm Dr. Rob Rozbruch from the Hospital for Special Surgery, and what we're going to do today is talk about complex ankle fusion as a technique of limb reconstruction. This is going to be as if I'm speaking to a patient for a preoperative education visit so that you can understand more about the procedure, why we do it, what are the indications, what's the usual routine, and so on and so forth. Well, ankle fusion is an operation that is done when the ankle joint is destroyed. Fusion used to be sort of the mainstay of treatment for all types of ankle arthritis, and that's not really the case anymore. Most of the time, regular ankle arthritis or routine ankle arthritis is going to be managed with other modalities. But there is a place, and in a very important place, for complex ankle fusion, and it's usually in the setting of a very severe ankle deformity that is associated with advanced arthritis of the ankle, or in a situation where there's an infection in the ankle that is related to a previous trauma. Oftentimes there'll be bone loss in the ankle area, such as a patient who has a failed pilon fracture. An infection may have developed that has led to infection in the bone and bone loss. These become more problematic and much more complicated problems to deal with, and in many cases they're really limb salvage situations. In order to save the limb and to give the patient a functional limb, what we need to do is stabilize the ankle joint, even in the setting of severe infection or in the setting of bone loss. And that's why it's called complex ankle fusion rather than routine ankle fusion. This is not a simple ankle fusion that is done with a couple of screws. This is an ankle fusion that is typically done with one of two major techniques that we will use. One technique is using a circular external fixator, otherwise known as the Elizaroff or Taylor spatial frame. And the second technique that I will use for this is an intramedullary ankle fusion nail that's inserted from the bottom of the foot. So the external fixator is an external device, the rod is an internal fixation device. And those are my two main tools, and I have various indications for one versus the other, which I'm going to go over with you. But I always have both of them available in that type of situation. If there is no infection, if there is good geometry that can be restored after correcting the deformity, and if the subtalar joint is not worth preserving, meaning it's already been damaged, it's already fused, then a intramedullary rod technique is a great technique for this. We correct the deformity, we align everything, we prepare the fusion site, and then we insert the rod from the bottom of the foot. In some cases, even in the presence of infection, we can use a rod because we can coat the rod with antibiotics in a cement mixture that actually coats the surface of the rod. The other technique that's utilized is a circular external fixator, and that is an excellent technique when we're dealing with bone loss. It allows the ability to gradually bring together or close down a bone defect. It's very good when there's a very severe deformity because I can gradually correct the deformity. It allows me to add additional compression at each visit, which is a great enhancement to bone healing. And again, in cases of infection, since there's no internal hardware, it's an excellent tool. Furthermore, in cases where there is bone loss, the fusion and the whole situation is one that results in shortening of the leg. And so the external fixator can actually be used to then lengthen the leg in a different area of the tibia to make up for the leg length discrepancy. So for example, if somebody has a failed pilon fracture, they're missing 1.5 inches of bone in the ankle area, as we do the fusion, it's going to be obligatory to bring the bone together and close down the defect. That will lead to a leg length inequality of about 1.5 inches. Well, we can build a lengthening component to the frame at a different location so that while the ankle fusion is healing, we can lengthen the leg simultaneously and achieve not only salvage of the limb, correction of the deformity, stable ankle joint, but also equal and optimal leg lengths. Patients are typically treated with an anesthetic that is a regional, which means they do not need to have general anesthesia. The usual amount of time for this type of surgery is approximately 3 hours. The surgery has two components. One component is preparing the ankle joint, and that's an open part of the procedure. And the second part of the surgery is the fixation. So during part one, I am correcting the deformity. I am removing any bone that may be infected. I'm optimizing the geometry. And in part two, I'm applying the external fixator, or I am inserting the intramedullary rod, depending on which technique we're going to use. If I can use a rod, meaning if the alignment is such that a rod can be accepted, then that is usually the more simple technique. The external fixator is reserved for more complicated situations. Hospital stay for these procedures is typically anywhere from 3 days to 1 week. Now, what would lead to a patient needing to be in hospital for a week is when there is a concern or when we know that there is an infection in the joint. When there's an infection, we take intraoperative cultures and we wait for those cultures to yield an answer. If there is growth of bacteria, we'll know that, but it'll typically take 4 to 5 days. During that period of time, we get an identification of the bacteria, and we'll also get sensitivities. And with the help of our infectious disease colleagues, we'll know exactly what we are treating. We will start the antibiotic treatment immediately after surgery, and it takes about a week to kind of initiate that treatment and get everything worked out for a home program of antibiotics that will follow. That typically is done over the course of 6 weeks. I do want to make one point is that we always hold antibiotics prior to surgery when we're concerned about an infection, because we want to get tissue specimens during the surgery at the time of the fusion that are going to be the most reliable. And those tissue specimens are going to really give us an answer about, is this infected? Is there a chronic infection? And what are the bacteria? Because by knowing the answer to that question, we can effectively treat that while we are simultaneously achieving the fusion. When patients do go home, we start weight bearing. Now, if the patient is in the frame, the typical weight bearing scenario is weight bearing as tolerated. The only exception to that are going to be patients with neuropathy, where I will limit the weight bearing for a period of time. And the time that somebody's going to be in a fixator is going to typically vary between 4 and 6 months. And again, that has a lot to do with the quality of the bone. Very rarely less than 4 months, very rarely over 6 months. If I'm using a rod technique, then I typically will have the patient wearing a cast for about 6 to 8 weeks with a limited weight-bearing type situation for the first 6 to 8 weeks. After that, they'll go into a cam walker boot and start weight-bearing as tolerated. When the fixator comes off after 4 to 6 months, patients are transitioned in and out of a cast pretty quickly, and then they go into a boot, and the recovery continues from there. Patients who have this surgery don't have all that much pain after surgery, and the usual routine is for patients to be on a narcotic pain medication for a few weeks, and then typically can stop that. If somebody is on antibiotics because there is a chronic infection in the ankle, that is typically done after 6 weeks. If there is a leg length inequality, and we want to treat the leg length inequality simultaneously with the ankle fusion reconstruction, I will typically take the patient back to the operating room in a staged fashion, do the tibia lengthening so that we can start the equalization of leg lengths, and the lengthening and the ankle fusion will happen simultaneously. In either scenario, patients are typically out of the fixator within about 6 months. Well, if you've got a fixator on, then some of your responsibilities are going to include cleaning your pin sites and making sure that we avoid and reduce the likelihood of pin tract infections. We teach you how to do that, and that's something that's going to be necessary on a daily basis. You can shower daily. You can go into a chlorinated swimming pool. If a superficial pin infection occurs, you let us know about it. We typically will put you on an oral antibiotic for about 10 days, and that usually takes care of the situation. If there is deformity that is being gradually corrected, the other responsibility is going to include making adjustments of your fixator so that you can gradually correct the deformity. Sometimes this is necessary, sometimes it is not. It depends on the individual situation. Your responsibilities will include follow-up visits with me on a regular basis so we can monitor the frame, monitor the pin sites, and monitor the bone healing. If you are being treated with an ankle fusion rod, then your responsibilities are going to include limited weight bearing for the first several weeks after the surgery. And following that, we get you out of the cast and start a weight bearing routine in a cam walker boot. The post-op routine in many cases with a rod is more simple because there's nothing outside the leg. Just regular follow-up visits with me are what's going to be necessary. In summary, complex ankle fusion is a surgery that in many cases is limb salvage. We're often doing it because there's an infection in the ankle, there's bone loss in the ankle, and we're doing it as an alternative to a below-knee amputation. It enables stabilization of the ankle and will also allow us to optimize the leg lengths by doing a staged or simultaneous limb lengthening surgery. The two main techniques or tools that I use for this are a circular external fixator or an intramedullary rod. The intramedullary rod can be a straight rod or it can be even a rod that is coated with antibiotic cement. With these tools and techniques, we've been extremely successful in achieving a stable and painless ankle fusion for patients who would otherwise often need amputation. So if you look here, what I'm showing you is a fracture that was taken care of at another hospital. This was the initial stabilization, and that was converted to this for this complex pilon fracture. You can see this is the articular surface of the tibia that's been severely damaged. This is after it has been revised with plates and screws. And while this looks good on first glance, the problem is a patient presented with infection. And it turns out that this entire piece of bone, which is about 4 centimeters or 1 3/4 inches, is just a dead, infected piece of bone. And in order to appropriately reconstruct this, what we needed to do is excise that segment of bone and perform a complex ankle fusion. So what you can see here is the tibia now opposed to the talus. This is the front view and this is the side view. This is the talus and this is the tibia. And you're seeing an external fixator in place. Now this is the bottom part of the fixator that's stabilizing the ankle. And then what we've done here is we've added another part to the fixator so that we are lengthening the top part of the tibia. So that's the ankle fusion. That's the tibia lengthening. And that's happening at the same time. Ankle fusion and tibia lengthening to make up for the 4 centimeters of bone loss. Now what you can see here in follow-up is it is all healed. The ankle fusion is solid and the tibia is solid. And this is the 4 centimeters of new bone that we grew in the top part of the tibia to compensate for the dead, infected bone that we needed to remove down below. This shows you that even after an ankle fusion, patients can really maintain an active lifestyle. And you can see that here with his skiing and with his mountain climbing. Hi, Lawrence.
Hi.
How are you?
Good, thanks.
Good to see you. So we're about 2.5 months since the complex ankle fusion that we did.
Been dealing with arthritis since I've been 30, so I've had 2 knee replacements. Both ankles needed fusion, so I decided that the pain was enough, so I decided to go for an ankle fusion. And everything that could go wrong went wrong. It got infected. They called it a non-fusion. They went in, tried to clean the infection. They went in 4 months later. They went in, took the plates out, and at that point they recommended amputation.
This looks very, very good. So you see we got the 2-ring frame here, stabilizing the ankle. And we've got some pins here. You're doing a great job cleaning the pin sites. I don't see any skin infections or any problems with that. So that looks wonderful. And same thing over here from the side.
I kind of look at your foot and I like my toes. So I had to get I had to get a different opinion. I went to Massachusetts, Boston, and met a doctor there, and he looked at it, and he says there's other things that can be done. He mentioned the hospital for special surgery, and then Dr. Rozbruch's name was brought up, and that's what got me to come to New York City to get it fixed.
And what we're going to do is I'm going to give you a little bit of extra compression to squeeze the bones together to help with the healing. Okay? Now you're still taking the antibiotics.
Yes, I am.
Okay. I'm going to want you to take, I know we had you on the intravenous antibiotics for a period of 6 weeks, and I do want you to continue the oral antibiotics, and we're going to do that until this is completely healed and until the fixator comes off. Okay?
Okay.
So why don't we do this? Let me get you to take a few steps over to the x-ray. You know, we are letting you put some weight on it. That's great. I love the way you're walking. That's fantastic. And I will tell you, I'm looking at you from behind here, and what I can see is that your foot is nice and straight, your ankle is nice and straight. And with a little bit of a lift on the shoe, everything is equalized well. This is a view looking at you from the back, and you can see how crooked this is the heel bone, and you can see how crooked the heel bone was, that it wasn't even underneath the tibia. You can see over here, after your previous surgery that you had done that wasn't quite successful, how the ankle didn't heal, and this is a non-union of the ankle. And then subsequently we found out that this was actually infected. That's why we went in, we cleaned it out, and took care of all that. Now the situation looks much different. This is the front view on today's x-rays. And you can see this is the top, this is the fixator, and this is the ankle fusion, which looks great. You can see everything's nice and straight. This picture really shows things nicely. This is the side view. And you can see the tibia, and you can see the heel. And you can see this is the junction of where the fusion is now. And everything is being squeezed together very nicely. It's compressed. It's very healthy. You can't even really see the fusion site. It looks so, so good.
Every visit's is a plus, because everything's positive, and how can you not like it?
You know, as you know from some of the other opinions you got, this was a limb salvage surgery. You know, this was really a way to save your foot, and I think you have a good foot. And just by taking care of this ankle non-union and complex problem with infection, we'll really be able to have you'll have an excellent result. Super. I'm so happy to see you.
Okay.
Great seeing you.
Thank you so
and
much.
My pleasure. And I'll see you in 6 weeks.
Okay.